All right. I think we should get started. This is really only a 1-hour program, but thank you everyone for joining us. So welcome to the Tri-State Obesity Society online event, Obesity Medicine in the Age of Telehealth. TriOS, as some of you already know, is a professional membership organization. We're dedicated to promoting education and networking opportunities for the whole obesity medicine community. We created this event because we felt that we clinicians have gone through a very rapid transition into the telemedicine arena just over the past 2 months. And I don't know about you, but it's been a pretty steep learning curve for some of us. And really, I learn the most when I talk to other clinicians, more so than my billing administrator, for example. So this is really that forum. What I want it to be is an open discussion for everyone to contribute their ideas and their thoughts. We've invited 2 of our members to lead this conversation, and together we've collated a bunch of information from various sources, including our own experiences, to help answer some of the questions and answer some of the cases that some of you have sent in. Just so you know, we will be mentioning commercial products, but this is in no way any endorsements, and certainly not any paid endorsements. And if there are other products that you like, please feel free to share. And then also for your information, this event will be recorded. Now, let me just quickly orient everyone to Zoom. We are probably all experts at this by now, but at the very bottom of your screen, there's a toolbar. If you don't see it, you might need to hover your mouse cursor at the bottom of the screen, and there should be an icon for your chat box. If your window is too small, you might not see that chat box. You have to click on the ... that says more, and then with that, you can open the chat. That chat will open to the right of your window, and that's where I want everyone putting in their comments, putting in their questions. Make sure that the to pull-down menu is to everyone if you want to share your comment with everyone. You can change that to the host, which would be me, to Beverly Chang, if you want to let me know a thought and you want me to share that anonymously. So I actually ask, if you're comfortable, please go ahead, use the chat box, introduce yourself, give us your name, what you're doing, where you're from. If you feel like it, share something that you learned or wish you knew over this lockdown, just to kind of get the conversation started. And then finally, I will mention that if everyone could please keep themselves on mute for now, there will be an opportunity to talk yourself towards the end of the event, where we will have some time set aside for a Q&A. If you throw in comments during the talk, where if our presenters prompt you for other thoughts or comments, then continue putting it in the chat box, and I'll mention it as we go along. Okay. All right. And with that, let me introduce you to our speakers. We have today 2 board-certified TriOS members whom we invited to lead the conversation on obesity medicine in the age of telehealth. Dr. An Chen is a family medicine physician who runs his own private practice downtown. He specializes in sports medicine, obesity medicine, and telemedicine. Dr. Rashmi Srinath is an endocrinologist and assistant professor at Mount Sinai Hospital and is the director of the Weight and Metabolism Program at Mount Sinai. Thank you to you both for being here.
Thanks, Beverly. Well, I'm excited, obviously, for our conversation, and welcome everyone. As Beverly mentioned, I practice endocrinology and weight management at Mount Sinai, and I will say from a personal experience, I started doing a little bit of telemedicine this fall in the version of video consults, particularly helping with my patients, particularly with regards to medication titration. And then recently, as most of us, became fully immersed in it in March in the form of video consults, e-consults, all forms. And what I first wanted to start with was just some basic definitions. What is telemedicine? So telemedicine, in my view, is a communication of electronically occurring between patient-provider or between providers themselves. And as Dr. Aroni mentioned, it's really crucial and helpful, for our patients. We know that patients with obesity are really high risk with regards to severity, complications related to COVID-19. And obviously there are a lot of challenges getting to providers and getting to be seen by us. There are various forms. So as many of us are doing these virtual video visits using either MyChart, Zoom, Doximity, various forms of communication. There are e-consults, which can occur both for the inpatient setting and the outpatient setting. And I personally have used both and have found them, and I've been responding to a lot of these and found them really helpful. There's also remote patient monitoring. So this is a form of communication where patients are communicating, whether it be their continuous glucose monitor data or other forms of information on various software services. And lastly, there are asynchronous communications. These are communications that are disparate in time, whether it's responding to emails, portal messages, and these are things that we can now get credit for and revenue for. So if you don't mind introducing us a little bit about yourself and how you have practiced telemedicine.
Absolutely. Thank you, Rashmi. Good evening, everyone, and thank you for being here on a Monday evening. I'm Dr. Chen. I work in downtown New York, and I've been practicing telemedicine since finishing residency. The purpose of this talk is hopefully I can share with you some insightful information you can all use. All right. First and foremost, you have to look good and feel comfortable while doing telemedicine. Let me elaborate. When you look good, you feel good, and you will do your patient good. Good lighting is very obvious. You really want the light source to be projecting onto you. What do I mean by that? You want to sit in front of a window where there's natural light coming in for best results. You have to have a good connection. Obviously, this is needed. I recommend a wire Ethernet connection with a minimum of 100 download speed and a 10 upload speed. You want to provide some good and concise information. Be clear and concise, obviously, but also be ready to repeat yourself. Next, you want to have good energy. You need to be smiling at all times and welcoming. Making the patient feel personal really allows them to open up and tell you their stories. Being positive will also encourage patients to comply with the recommendations and follow up appropriately. Now, why are these obvious suggestions important? Well, as telemedicine becomes more popular, guess what? Patient will soon be able to give grades and ratings based on their visit. Now, what makes a patient appropriate for telemedicine? From my experience, these are some of the things I want to emphasize on. They have to be motivated, meaning they have to be ready to take notes during the visits. They have to have questions prepared. This all makes the visit more constructive and it flows nicely. They also have to be well informed about their own health, such as knowing their own heart rate, knowing their blood pressure, knowing their recent labs really helps the visit. More importantly, knowing the medications and the dosages they're on. This makes the visit just worthwhile, and it makes it easy on you. Lastly, they have to be able to communicate their wants and needs effectively.
That's a great point, Ron. I will also say part of telemedicine, just being professional, is also appropriate documentation. And that means being honest, being accurate in what you're describing, everything to the extent of what you're discussing with a patient, including a physical examination by inspection. Given insurance companies right now have become a little bit more lenient when it comes to time-based billing, so they know you're putting in more effort. So you can now bill based on complexity or based on time and indicate the time you have spent preparing for a visit, conducting the visit, and coordinating post-visit care. So that can sometimes raise you from level 3 to 4 or more based on how much time you're actually spending. It's also important that we get credit for the work we're doing, whether it's responding to phone conversations or responding to messages. And our administration is now recommending if a patient responds with a question, you set up a scheduled telephone call or a video visit and you answer that question and you're able to bill for it. So these are all very important ways that we can communicate and work on getting credit for the work that we're doing.
I totally agree. Documentation and physical exam has become even more important. The good news is that certain telemedicine company will have the visit recorded, so the video and audio will be recorded for this entire time. Rashmi, it sounds like you've been thrown into this telemedicine realm recently. What other challenges have you encountered with your visits?
Well, I think some of the challenges I'm sure you guys have all experienced is, you start a patient visit, you click, and if it's a new patient, you see their face and it's a introduction. And, sometimes that means really not having much data. I'll share a patient vignette with you. Just last week, a 39-year-old came to see me. She had class 3 obesity. I had a weight of 232 pounds. And from looking through our EMR, I realized she hadn't seen her primary care provider for about 6 months. And the last weight at least was 6 months ago. And she hadn't had any blood work for over 9 months, which in my mind is a long time. So that brings up the question of what is needed preparing for these visits. So many times, I'm going into a new patient visit, looking into the EMR, looking at their weight trajectory, looking at their prior blood work, looking at outside labs, grabbing that data so I have a little bit of preparation, and that does take time. In the moment of the visit, usually I'm asking the patient for a weight. If they have a scale and they haven't done it, I coach them through it, even if it means not looking at the scale itself. If they don't have a scale, many times I'm asking them, do they have a dress size or their pant size they can share for me? And also looking at how that size has changed over the last few months. We all know that it's important to get a 24-hour food log for a patient, and I'm not sure how you guys feel, but I feel like my patients are a little bit more honest with me. Many times they're showing me their blender, their protein shake, their prep, their plates, and what they're eating, and I found that actually is quite nice. When I'm asking patients about their activity level, I think many of my patients, because they're in their home environment, they are very blunt, and many of them are saying, no, I'm just really not that active. And it's important to ask them what exactly they are doing, how many steps they're taking, and how is that different from their prior activity level. In terms of also gathering data, we know that there's only so much you can get from looking at someone's face. We also gather a lot of data from looking at their body habitus and inspections. So using telemedicine, we can conduct a physical exam, and you can get credit for a physical exam through inspection. So you can have them check a blood pressure if they have a blood pressure cuff. You can have them measure their pulse. You can have them turn their neck to see if they have acanthosis. You can have them show their extremities to look for swelling or edema or other concerns. So it's really important that we do as much of a physical examination as possible to gather information and really conduct our visit to the best of our ability. So given some of the challenges, as I mentioned, gathering data, sometimes you have no data in front of you. There's also been a lot of changes in patients' food environment. And I was curious, given you've had a lot of experience with telemedicine, how have you adapted your nutrition counseling and how you address some of the patients' concerns these days?
In one word, I make it simple. Counseling on nutrition is actually very difficult because we're not simply talking about foods. We're empowering patients how to effortlessly restrict tasty, sugary, really good, enticing foods. And this is really hard. Well, let me share this example with you, all right? I had recently had a 51-year-old female, class 1 obesity, a BMI of 30.8, at a weight of 174, pre-diabetic, osteoarthritic as well. She comes in for weight management. She's been working from home since the lockdown for 3 months now, and reports snacking throughout the day and eating comfort foods at night. And this is something we can all relate to. So how do I counsel this patient? Well, given there are tons of information on diets and supplements on the market right now, it can be all very confusing, okay? And given the current public health situation, I need to make things realistic. I keep it simple, especially with the new patients. I introduce them to intermittent fasting, the 16/8 plan. Simply, you can only consume foods for 8 hours throughout the day. So the patient is allowed to eat from 12 p.m. to 8 p.m. This means they're fasting for 16 hours and eating for a total of 8 hours. Nothing other than water or medications are allowed after 8 p.m. I tell my patients this, so once they accomplish this goal, they can move on to more advanced nutritional counseling. So what about you, Reshmi? What have you been telling your patients about nutrition?
I agree with you. I think intermittent fasting definitely lends itself to, the recent environment we're in, and it creates some structure around patients' environment, telling them, if they can have to stop eating by 8 p.m., that limits them from doing some of that snacking. I've also done a lot of counseling about lower carbohydrate intake. So I am telling my patients, start your meals with a high protein breakfast. I'm doing a lot of counseling on carbohydrate intake. So usually if I were in my office, I would have a picture like on the upper left demonstrating what are carbohydrates, and I would go over this with my patient. What are the good carbs? What are the bad carbs? But right now, obviously I'm in my home and I don't have all of that. So I'm doing a lot of movement with my hands, and I'm sort of telling patients, this is a fist. This is a serving of rice or grains or pasta. If you like rice or pasta, limit yourself to 1 to 2 fists. The rest of your plate should be protein, vegetables. Similarly, the size of my palm, that is a serving of protein. And a lot of this counseling around serving sizes and portions and I'm doing that in the moment. The other thing I've realized is that with regards to nutrition counseling, some patients do have a little bit more time on their hands, and they are a little bit more anxious, particularly with regards to regain. And so what I've done a little bit more emphasis is on food logging. We know that there is good short-term data that logging your food intake does help not only with patients achieving weight loss goals, but also maintaining exercise and diet plans. And so I am recommending to my patients to chart their food intake, whether it be using Lose It, MyFitnessPal, or the app of their choice. I think logging their food intake, targeting a caloric restricted diet helps them not only achieve their goals, but also with weight loss. Given some of these changes, I thought we might want to ask the audience if they want to share some of their experiences with nutrition counseling. Absolutely. If you want to share in the chat box, please do.
Sorry, I just had to unmute myself. Actually, Reshmi and An, there was a question earlier about billing, but maybe we can address that towards the end. People were wondering, how exactly can we get reimbursed for all of that asynchronous communication that you mentioned telemedicine is part of, the portal messages and telephone calls, emails, that back and forth.
Yeah.
Then there was another point about which platforms are actually accepted for reimbursement by Medicare or even by private insurance companies. And I'll just share a comment from some of our participants that I think it does seem to vary. It looks like some platforms some insurances accept Microsoft Teams, which I actually haven't used. At Cornell, we use Epic, and Epic has its own integrated video platform that is accepted for reimbursement by insurances.
Yeah, at Mount Sinai, we've been using a lot of MyChart, but if a patient has trouble logging in, we have been using Doximity. You can conduct video visits with Doximity. If a patient really has a challenge and they have a Zoom account, I've been doing Zoom as well. There are some relaxed restrictions with regards to insurance companies that it doesn't have to be a HIPAA compliant medium. So many of these other sources are just fine, as long as you're conducting a video visit and you're indicating that. Great. Well, I guess I'll move on to the next point. We talked a little bit about nutrition counseling. Obviously, there have been a lot of changes in patients' environment, our environment. A lot of us are working from home. And I just wanted to raise a point of how have we adapted our counseling about exercise, given patients are sort of stuck, they're afraid, they're scared of going out. What have you sort of been telling people lately?
I tell them the same thing. Physical activity is great because it speeds up the progress of weight loss. The challenge here is to individually tailor an exercise routine that is enjoyable so that patient can be consistent and continue doing it while enjoying it. I actually have a patient, he's a 45-year-old male, class 1 obesity as well, BMI of 30.8 at 174. He's suffering from hypertension, dyslipidemia, he's coming in for weight management. And guess what? For the last 2 months, he's been gaining weight because he's staying at home and afraid to go out. He's been hesitant to go out for his usual runs, which are 2 times a week, and he's not sure how he can handle wearing a mask during exercise. So from my experience, patients fall into one of 3 groups when it comes to physical activity. First group, we got the patients who are afraid, who never exercise, and who dislike any type of physical activity. And then on the other end of the spectrum, we have those who are lifelong athletes who run marathons and compete in different sporting events. And then in the middle, obviously, we have the weekend warriors. So I'm tailoring my consultation differently for each one of these groups. For those who never exercise, I take very small steps. My goal is to mentally prepare them so they can initiate some type of physical activity in their lives. Simple suggestions such as just laying out their fitness gear, tennis shoes, shorts, and shirt the night before. This helps them with accountability and allows them to visualize their physical activity for the next day. Another advice I tell them is to have a workout buddy of a similar fitness level. Next, for the weekend warriors, these patients are working out 2 to 3 times a week and they enjoy doing so. They are usually running or strength training. With this group, I advise them to mix and match. If your main activity is running, I would add a day of resistance training. If your main activity is weightlifting, then I would add a day of aerobic exercises. And lastly, we have the third group, the marathon runners, the lifelong athletes. They are all very well versed with all types of physical activity and trainings. With this group, I focus on preventing injuries. It's perfectly okay to feel sore the next day after a good workout, but it's never okay to feel pain in your joints, in your bones, at all. I remind them of their goals. We are not training to win an Olympic gold medal here. We are training to lose excess body weight. So Rashmi, how have you been counseling your patients on physical activity?
Yeah, I agree with you. I think there's definitely a spectrum for those patients who are really afraid either due to comorbid conditions or due to underlying health issues and they just can't get out. I am recommending exercises in bed, whether it be stretches, using an exercise band, even chair exercises. Sometimes I even demonstrate doing dips, push-ups, things on your chair if you can. For those who are walking, I think the issue is really sort of a resetting of your daily routine. And I think for most of us, you know, if you're active, clearly our routine has changed. We are now doing video visits. We're active all day or busy working all day. And what I'm telling a lot of patients is that if you want to go for that walk, find a time where you're not afraid, whether that be early in the morning or early evening, there's not as many crowds. That's really the time to get your exercise so you can get around some of those fears and at the same time get that activity level. With regards to those who are already active, I'm definitely telling them to mix it up. As you said, if they're already doing cardio, add some weight training or add some toning. And I really like just going to YouTube, looking up some websites, whether it be a Zumba video or a cardio kickboxing video. I like websites like fitnessblender.com. There are a lot of variety of videos there. I also feel like those patients who came into this very active, they are doing a lot of research on their own, and I've learned so much. I put some apps out here that I've learned and I really like. The 7-Minute Workout app is a favorite of mine. Sworkit, MyWOD, or My Workout of the Day, Fit On, Nike Training Club, even Peloton. For the last 90 days, Peloton has been offering free service, and for those of you, you know, who don't have a bike, you can still use Peloton and do resistance training, do cardio forms, do Pilates, yoga, any form of exercise, even without the bike. So I think it's sort of addressing a patient's ability to exercise and at the same time addressing their fears and working with them so that they can add activity to their day. Because as most of us know, we are classically very active and this environment has changed drastically just in the last few months. And that has precipitated a lot of the weight gain that we're seeing. And I was curious, again, if the audience wants to chime in with any thoughts on how they are counseling about exercise, please feel free. Beverly, please let us know if there's anything that comes up. We'll pause for a few minutes.
Okay, we'll continue.
Okay.
All right.
Oh,
So
sorry, just one thing.
Oh.
We had an example from one of our endocrinologists that working out with stuff at home like laundry detergent and water bottles are a very good idea. So I'm sure some people have very heavy laundry detergents or water bottle gallons that can also be used as weight for resistance training.
Yeah, that's a good point. I think you and others had said, you know, sometimes even lifting the heaviest thing you have in your house and seeing if that, at least if it's a reasonable weight, seeing if that can increase, again, resistance training, any form of activity is definitely helpful there.
Yeah, yeah. And I agree as well. I think she's mentioning the 3-gallon water jugs, and they come with a perfect handle. So it's easy to lift and do your workouts. So
we have one other question. When might you consider referring a patient for physical therapy?
So I think, and I'll answer this first on, I think, if a patient is really limited in their activity, if they had been engaged in physical therapy before coronavirus came, I think definitely, and if they're having active ongoing joint issues, whether it be joint pain, osteoarthritis, I definitely think considering it. I think we also have to address their fears. I have a lot of patients who were engaged in physical therapy, had stopped because they were afraid of getting out. And I've since learned that a lot of physical therapists are engaging in Zoom or virtual visits just like we are. So I think it's sort of addressing a patient's needs. If they're really inactive, that's definitely a priority to consider.
In addition to that, Rashmi, I want to add physical therapy, especially when you're personally related to the physical therapist and you know they're doing good work and they know the type of patient you're sending. I actually recommend it right from the beginning. This way they can do the exercises appropriately and prevent injuries from even happening. Any other comments? Okay. So far we've addressed nutrition, we talked about physical therapy. Let's go on about medications. Rashmi, have you found yourself prescribing anti-obesity medications any differently in regards to being less or more aggressive? And how are you giving instructions in this time?
Yeah, so that's a good point. I think given, as we mentioned, our environment has changed, I've found that my patients are more sensitive or more aware of their body. I think there's a lot of sensitivity, a lot of anxiety, just given everything that's going on in the world. And so definitely, I think patients are feeling a little like they're more aggressively in terms of wanting help in terms of pharmacotherapy. And I think on our side, we are feeling that pressure as well. I will suggest, a patient big night of mine recently, a young woman, 25 years old, came for follow-up for class 2 obesity. She had a BMI of around 36. She was on around 184 pounds, and she already had instituted a low-carb diet. She was eating quite well, charting her food intake, her macros. She was exercising 3 to 5 times a week, and this was a good combination of cardio weight training, and we had talked about really creating a diversity in her activity level. Unfortunately, just with the coronavirus epidemic and the quarantine, she really had plateaued. And she came to me for follow-up, last week saying, I'm doing my best. I really need help. What can I do to really boost and help me lose weight again? Because I'm stuck. And I think this is where, as providers, we have to be really aware of our comfort level providing medications. Given this is not an in-person visit, this is a virtual chat or conversation. I always start first with diet lifestyle modification because I know that there are always ways to optimize that. There are always small tweaks that you can make with regards to patients' eating habits or their activity level. And yes, when patients are clearly doing their best, I am using phentermine short-term. I am using Qsymia. And I am feeling comfortable doing that even though it's not an in-person visit. One of the nice things about telemedicine is that we can utilize frequent follow-ups now to help monitor them. So if I start them on Qsymia or I start them on phentermine, I can follow them up in 4 to 6 weeks in a video visit or earlier and see how they're doing, if they're having any adverse side effects, if we're responding well. We know that that response in that first 6 weeks or so does play a crucial role in how they respond long-term to these pharmacotherapeutic agents. The other point I want to make is, we now have a diversity of pharmacotherapy, and it's really important that you provide instructions appropriately. I had a little bit of a mishap earlier this week where a patient of mine, I started them on Saxenda, and I then provided instructions to them via video. I instructed them on administration technique and how to adjust the dose. They then went to the pharmacy, picked up the prescription, and immediately, as soon as they went home, they dialed up to 3 milligrams, and they started 3 milligrams daily. I then got a MyChart message a day later saying that they've been nauseous and vomiting for 36 hours straight. And of course, my mistake, they forgot everything I told them in the visit. And that made me realize that sometimes, you have to consider, written, like you provide written discharge instructions. In my office, we sometimes give them a paper describing the medication, the side effects, how they titrate. of course, that's not really provided in a face-to-face video visit. So I am now starting to write out medications and write out a message after my visit saying, hey, we are starting this medication on you. You're going to start this. And by sending them a message and providing that written expression of instructions, I think many patients remember that better than what you tell them face to face. So I think, again, the point is whatever pharmacotherapeutic agent you're picking, you have to provide appropriate instruction, and you have to, I mean, it's more work on our side, but I think writing out the instructions, sending them a message afterward, giving them an update, this is what I'm telling you to do, can help so that your patient doesn't call you and say, I'm nauseous and vomiting for the longest time and I never want to take Saxenda again. So I think that's a good point. The other point just about pharmacotherapy is these frequent follow-ups do help you, because then you start seeing how they're adapting their diet lifestyle modification and how to adapt and see, what are the reasons for them really to plateau. And so I feel like telemedicine has helped us from that perspective for sure. And I was curious again to the audience, please shout out if you have any, or sorry, write in the chat box if you have any thoughts onto how to manage pharmacotherapy, and especially if you're feeling comfortable with these video visits, prescribing some of these medications, including phentermine and Qsymia. And I'll have Beverly please share anything you.
Nothing for now. I think we can continue.
I have a comment. I actually had patients tell me they really enjoy having discharge instructions in front of them, and they appreciate that a lot, so they can go over the visit and not forget anything. That's important.
Yeah, definitely. Well, as I mentioned this, our environment has changed. Patients, a lot of my patients seem to be a little bit more aggressive with wanting pharmacotherapy. I was just curious on if you've also experienced the other side of it, where patients are desiring bariatric surgery and they're asking for it. I'm curious to hear your experience with that.
Yes, I actually do have a few patients asking me about this, and I tell them the same thing. I tell them bariatric surgery is great, it's an effective procedure, and it offers great benefits. But I had a patient who was 57. He was a male, class 3 obesity, a BMI of 36.6. He was weighing at 255 pounds. Comorbid conditions include uncontrolled diabetes, sleep apnea, and GERD. And he was very fearful of what's going on with COVID-19 and his obesity issues. And he wanted to be more aggressive with weight loss. And he was asking, should I do the bariatric surgery? He said, if I lose enough weight now, will this protect me from the COVID-19 the second time it comes around? Now, this is a very real thing. And my recommendation at this point is to hold off on elective surgeries because the current health system is overwhelmed and stressed. Most of these patients, or most of my patients, have been battling weight loss for their entire lives. So holding off for another 3 to 6 months won't drastically affect their overall health. Why? Because post-surgical complications and post-surgical care is a real thing and it's important. And I don't want my patients to be battling these hurdles at this time. In addition, concrete evidence between obesity and likelihood of contracting COVID-19 is not sufficient for me to rush them into the OR yet. Instead, I take this time to counsel them and optimize their nutrition. I optimize their physical activity, and lastly, their medication use. Reshmi, what are you telling your patients about considering bariatric surgeries?
Yeah, I think it's a good point. I think patients are definitely more interested. They're obviously, like as I said, they're more aware of their weight and what's going on in the world. And I think the first step is addressing their fears. A lot of patients are afraid. They're reading all online about how obesity is a risk factor for COVID and complications, and that obviously creates a lot of fear and anxiety. I think the first step is as you mentioned, optimizing diet lifestyle modification, and really just counseling patients on what are their realistic weight goals. So if they are looking to lose over 50 to 100 pounds, and their BMI is over 40, they might be someone that you might more aggressively triage towards bariatric surgery. We also know that just losing at least 5 to 10% of their body weight can assist them with reducing some of those comorbid conditions and reduce their risk. At the same time, if they really are aggressively pushing for surgery, I am counseling them that there is a preoperative process. They are going to be seeing me or their primary care doctor, and we know now that it can happen virtually. I've been conducting some of these virtual sort of clearance visits, and they can start that process and get it going. And it does require weight loss overall, because the surgeons know to improve their outcome, they need to lose some weight before they even get the surgery. Most recently, the Diabetes Surgery Summit has released some guidelines just in terms of triaging patients, and we know that those who have underlying diabetes, comorbid cardiac disease, or metabolic complications, these are patients who you might want to aggressively triage towards surgery. And I think you mentioned the good point that the system's under stress. We just got our email saying that our elective surgeries are now about to start. They're open. So I feel like, there definitely is going to be a huge boom in referrals for bariatric surgery. And I think it'll be interesting to see how those referrals have changed from the pre-COVID area to the post-COVID area. But I think for sure, it's important to triage patients based on, as you mentioned, diabetes, underlying comorbid conditions, and see how they're doing. And I was curious, again, please feel free, audience, if you have any thoughts on referring patients to bariatric surgery, please chime in. We're happy to discuss those thoughts.
And do we have any surgeons in the audience?
No?
I am a surgeon. I'm in Mexico.
Excellent, excellent.
Hello, welcome, Dr. Perez-Galaz.
Hi.
Are you aware of the new the recommendations for triaging patients for bariatric surgery?
Sorry, the connection is actually very bad here.
Okay, that's all right. We're actually, then you know what, we're going to go ahead and we're going to be going into the Q&A very soon, right after our speakers just finish up for us.
All right, great. Let me quickly summarize what we talked about so far. We started off with the basics of telemedicine and provider etiquette. We also mentioned about documentation and importance of doing a physical exam online. Next, we entered the nutritional counseling. We're using intermittent fasting and controlling portion sizes. And lastly, measuring macros by hand. That was followed by counseling on physical activity, exercising at home, based on their fitness level, and using apps to benefit our patients.
And at the same point, again, addressing patients' concerns about pharmacotherapy, feeling comfortable prescribing stimulants in the setting of a video virtual visit, and being sure that you provide appropriate discharge instructions, communicating medication titration, medication side effects to your patients, and similarly, addressing their concerns, their fears about obesity, their risks with COVID-19, and stratifying them, if they really are qualified for surgery, have underlying diabetes, comorbid conditions, they need to be aggressively triaged and starting sort of that preoperative process. Great. So I think we can start, Beverly.
Yeah, that concludes our presentation portion of this. We did want to sort of collate some of those highlights that we learned for everyone. But to open up the Q&A, if I could ask a few people to chime in here, because there's been a number of chat questions actually coming in about the prescription of controlled substances, particularly things like your sympathomimetics, phentermine, and Qsymia. I think the general idea is, how do you get vitals? Do you want vitals before before you prescribe? Do you want a baseline EKG? And I was wondering if Dr. Merkin could maybe comment on what she does, because she was mentioning here things about a digital BP and heart rate monitoring.
Haven't gotten really into doing weight management because I was deployed at the hospital, but I would require people to, I do like getting vitals. I feel uncomfortable not getting it and would require it for patients. And I think that it's a small, thing to ask people in general. I don't like spending other people's money, but I think it's not a huge investment for them. And since since they're probably saving money by a lot of them by doing telemedicine, I think that it's something that you could use, or they could go to CVS and do something like that.
Mhm. And Dr. Ye, I think you had a good suggestion as well. What do you do with your patients? I don't know if she's here.
Can you hear me?
Yes.
Oh, okay. I mean, I've only started one patient over a video visit on phentermine, and for her, she was already on Topamax, so I thought it was a good fit for her. But I made her go and get a BP machine at CVS, and basically send me 3 days of vitals of her blood pressure and heart rate before before I prescribed her any medication.
And then Dr. Anikwi, I'm sorry if I'm pronouncing your last name wrong. You're an obesity medicine physician from MGH. Thank you for joining us. Could you tell us a little bit about how you manage your patients?
Sure. So, like I mentioned in the chat there, I know now we are allowed with the new regulations to prescribe controlled substances as new patients coming in for telemedicine. And so, given those guidelines, it's definitely, I think, best to use your discretion, and seeing a trend of normal range blood pressures and heart rates would be one thing I would look for personally. Looking in their chart, if you have access to it, to see if there's any history of being on antihypertensive medications, and making sure that they're complying with those throughout this pandemic and stay-at-home period of time. And then if you're just uncertain, really just having them, as others have mentioned, provide you with recent vitals that they can obtain with blood pressure cuffs at home, or a lot of people have Fitbit monitors and different types of technology that they're using to monitor their heart rates at home. And even O2 sat, I had some people doing that as well. And then for now, since we do have a plan to be scheduling new patients for office visits in the relatively, maybe not near immediate future, but in the upcoming months, I would still have that as an option as well, just to actually have them come into the office for that new evaluation, see them in person, and if it's not of emergent importance, to get them started on a controlled substance right away. That would be another alternative that we can use.
Thank you. Thank you for sharing. And I just want to share one more comment that was sent to me privately. Some physicians, this one particularly looks like to be part of a pediatric obesity group, also use home BPs and heart rates and pregnancy tests for the kids who are on phentermine or phentermine and topiramate, which I think is a very good point that we haven't brought up yet. Dr. Srinath and Dr. Chen, do you have anything else to add?
Absolutely. I think we're all
Go ahead, on.
we're all doing the right thing with the vitals, the BP from the supermarkets and CVS. And I'm actually asking my patients to take a photo of it, and so they can send me the photos and show it to me online on their phone. What I do want to be careful is this. I actually had a patient a week ago who's been on phentermine and topiramate for a while now, and I know he's a good patient. The only problem is that he's not in the state that he was originally in. And because telemedicine made things really easy now, I felt just like prescribing to him. But then when he said he was in another state because he's traveling away from New York, I had to hesitate and just check my state laws and not simply refill his medications because I've known him for so long now.
Great. And then Dr. Aroni, I think you've added a couple of questions yourself. Do you want to maybe chat a little bit about your thoughts?
Sure. The first question I had is, do people use the dose of phentermine that's in Qsymia, 4 milligrams and then 8 milligrams, or do you just go right to half of a tablet, of a full 37.5 tablet, which has, depending upon who you talk to, 15 or 18.75 milligrams of phentermine in it? You go right to that. People feel comfortable with that, because we have been using the lower doses to have a defensible position that it's an approved drug for long-term use. So we tend to use a lot of that, and more than we used to. So I was just curious how people were doing this. The other question I had, which I think we should poll people, Dr. Chang, is have people seen patients who you've been taking care of or currently taking care of and who have lost weight do poorly as a result of COVID? And meaning ICU, intubation, and death. Because we've had a number of cases, very remarkable cases of patients who were, severely obese. 700-pound guy went down to 580, got COVID, and just went right through it with no problems. Oh, an outpatient, didn't even go to an emergency room. And it was shocking to me, but also his pulmonary physician couldn't believe it. And it brought up the idea of whether or not losing weight reduces the inflammatory cytokine hormones, prevents the so-called cytokine storm by clamping down on adipocyte hormones. And could that be part of the mechanism of action? So remember that with a 10% weight loss, you get a 50% reduction in hormones like leptin, which is pro-inflammatory. So it's at least theoretically possible that this is the case. To try to answer this, we're thinking about how we could answer this question. So I've asked one of the insurance companies we've worked with, who happen to have 40,000 people who've had COVID thus far as of the end of May, to look at how many of them have had bariatric surgery. And we thought that there might be an answer in there to see if people who've lost weight from bariatric surgery have the same or lower incidence of severe complications. So just some things to think about.
I will say, from seeing patients in the hospital, I've been rounding on our diabetes consults and our endocrine consults, that a lot of the patients who have both the obesity and the diabetes, and if it's poorly controlled, that combination really puts them at risk for that prolonged ICU stay and those severe complications with prolonged hospitalization. So I think that both the obesity and sort of underlying diabetes, that combination is really, really bad prognosis.
Yeah, I also have this, we had very weird cases of euglycemic DKA. For example, a couple of pregnant women showed up with, they only had pre-diabetes as underlying problem. And then they showed up with the euglycemic DKA, no, not even on metformin. And then another thing is that we really, obesity and diabetes obviously are huge risk factors, but we have a huge numbers of Hispanics and African American, unprecedented in terms of people with COVID-19 and extremely severe diabetes. The problem is also comorbidities and the treatment, because obviously the cocktail was often, for the people who were intubated, was steroids, tube feeds, and many of them, they were also on oppressors. And we had actually people who were on a medication, a pressor that was a alpha agonist, actually, was the most commonly associated with diabetes and bad outcomes in people with obesity and diabetes.
Yeah, I think personally at Cornell, we've been seeing very similar outcomes, though honestly, our population is a little bit skewed being on the Upper East Side. So I'm sure that those who work in the outer, so-called outer boroughs are seeing a different average BMI, for example. I just want to remind everyone to feel free to unmute yourself if you want to comment. We do want everyone to feel welcome to participate. We're getting comments through the chat, and it does sound like people are starting at the lowest dose of phentermine, to Dr. Aroni's question, and then working their way up only if the patient needs to.
I have a comment. Here in Mexico, I'm a surgeon in Mexico City, and actually we are at the peak of the pandemic right now, and what we are seeing is that we have a big mortality rate in young people which are diabetic, with hypertension, and with tabacism. And that explains why here in Mexico we have an 11% mortality rate in people between 45 and 55 years old, which is very high. And obese, of course. That's, 75% of all population here in Mexico has overweight and obesity. So it's a big problem here.
Actually, I want to add something about the age. Everybody in the news hears about, the elderly and COVID, but in the statistics in our hospital is that the vast majority of people who had COVID, they were between 45 and 60. Mostly men in 45 and 60, a lot of them Hispanic. So, and many of them had diabetes.
Well, that's practically the same here in my hospital, which is a 200 bed hospital in Mexico City, and the mortality rate is higher in the men, obese and diabetic between 45 and 55 years old. Great presentation, by the way. Thank you very much.
Great. I just want to wrap up a loose end from earlier. One of our physicians, Dr. Lucan, had asked for some clarification on how exactly can we get reimbursement for the asynchronous communication. And I can share the slides. I'll figure out some way to share the slides somehow, but there are particular billing codes that are available for that. Dr. Srinath or Dr. Chen, did you want to make any comments on that or elaborate?
I think that there definitely are codes. I was just looking back at the slide to look at, I think slide 4. There is a, basically, I think it's 99421. It's sort of like a basically, it's almost like an e-consult type digital code, but there are ways, and what I've done actually is reach out, as you mentioned, to the billing administrator to sort of ask them. I think it's easiest, as you mentioned, trying to coordinate some sort of visit, whether it be a phone, even a phone call, just to speak to the patient, because we know for sure those can be billed as scheduled phone calls to determine that. But yes, and again, one of the things I forgot to mention is there really are no guidelines with telemedicine. So I feel like a lot of us are learning day by day and experiencing this and growing as we do it.
I don't remember exactly the definition. However, we are getting a lot of pushback from our coders about what type of phone calls can be billed. And one of the major wording is it cannot be a conversation about lab results or many other things for which we do call the patients and we have phone calls. It has to be patient initiated, which personally I'm not sure exactly what that means. So there is a certain restriction on what kind of phone calls you can bill for.
Yeah, what I've done is I've added, like, in my schedule, I have like the video visits, and then I have a sort of like patients who want to talk to me, and I set up an established telephone visit. And this is sort of a separate sort of description of that visit. And that somehow has allowed us to bill for that telephone visit. But I agree, it's challenging.
My sense is that the the reimbursements for these asynchronous communications is fairly new, coming from CMS, coming from the private insurers who will follow Medicare guidelines. So when I spoke to my biller about it, it seemed like he didn't know and had to look into it for us, which I think, you know, it kind of falls upon the responsibility of the clinicians, because this matters the most to us, really, to talk to other people and figure out what everyone else is doing. I agree with Dr. Obici that it needs, the guidelines I've seen is that it needs to be patient initiated. So when the patient texts you, calls you, emails you, and you anticipate a somewhat full-length conversation, the documentation has to reflect that. The documentation actually has to follow some kind of a chief complaint, HPI, assessment and plan setup as well. And there should also be some sort of legal statement to say the patient is aware that this is a billable encounter, because a lot of patients have gone into these telephone conversations and chats with the expectation that it's free advice, right? Which is how we've been operating for a very long time, but may need to change in the age of telemedicine. All right, so we're coming up. We went over time a little bit. Let me just wrap up for you guys here. Thank you, of course, to everyone who came. Really appreciate you giving us your time on a Monday evening. I will say that if you enjoyed this, please keep in touch and keep an eye out for future events. By registering for this event, you have been added to our listserv. I promise I won't be spamming you guys. But if you do not want to receive communications, then definitely just reply to that last email you received and say so, and I can absolutely remove you. The second thing is because actually Dr. Chen has been our social media coordinator for the past few months, really getting us set up. So thank you for that. We do have a Facebook group now that is available. We're making it open to only members, so that when you do join that group and you're conversing with everyone, you can feel comfortable knowing that you are communicating with your peers, other people who are, you know, either very much passionate about obesity medicine, or they're already experts in obesity medicine. And as I mentioned, that is available to members only. You can go to our website, tristateobesitysociety.com, to learn more about membership. I just want to, of course, thank the panelists. Thank you, Dr. Srinath. Thank you, Dr. Chen, for your insightful comments. And thank you to everyone for joining us.
Thanks, Beverly.
Thank you.